Yes, so our next speaker is Dr. Padurean, who will be joining us from Romania, but actually working out of Germany, actually. And he will be talking about a project that he started working on about cervical spine disease and electrophysiology. Dr. Padurean, you're on.
Hello, everyone. Can you hear me?
Yeah, good.
Yes.
Thank you.
Okay, I'm sharing my... Okay, can you see my slides?
Yeah, we sure can.
Okay, so good morning, good afternoon, and good evening to everyone in their respective time zones. Thank you, Nathan, for presenting me and also for allowing me to live in your apartment for the last week. Relating to Professor Salman's question, this is the German Wi-Fi that I'm using right now. So anything goes wrong, it ain't my problem. Also, I'd like to thank Professor Oertel from Homburg for giving me the opportunity to actually come here and study this. Now, as a proof that this is actual research, the title of my presentation has already changed from the one that was included in the program. Now, although these are photos of me, I must say as a disclaimer that I'm definitely not a spine bro, and I'm not a research bro as well. I've just finished residency in December. I finished it in Cluj-Napoca in Romania, and I cannot say that I'm specialized on any of these subjects. But from the very first years of residency, I was always interested in cervical myelopathy and cervical surgeries, seeing how capricious the cervical edema was in a lot of patients in a lot of different surgeries, and the way and how unpredictable it was. Now, of course, my journey also started, as Emilio mentioned, by driving 2 days from my hometown in Romania to Homburg, and this happened just 1 week and a few days ago. Now, to put you up to speed, I think you all know that the degenerative cervical myelopathy is a progressive spinal cord dysfunction that is caused by degenerative extrinsic compression. So we're not talking about tumoral compressions here. And of course, it is the most common cause of spinal cord dysfunction in adults. And as we'll see, it can lead to quite serious deficits. Now, the main etiologies that cause cervical myelopathy are degenerative disc disease, so disc hernias, cervical spondylosis, OPLL, and DISH as well, or Forestier disease, and ligamentum flavum hypertrophy or ossification. And as for the pathophysiology, I guess you're all familiar with the cascade of mechanical compression, chronic compression that leads to ischemia, that leads to inflammation and edema, and then to neuronal damage, which worsens the patient's symptoms and signs. Now, apart from the clinical assessment of myelopathy, of course, we routinely use the MRI, and most often myelopathy appears as a T2 hyperintensity. But this is not always the case. The patient can also have clinical myelopathy without a T2 hyperintensity. And when we see a T1 hypointensity, then this has been shown in the literature to be more often a poorer prognostic sign for the patient. Okay, so for the natural history of cervical degenerative myelopathy, if it's left untreated, the spinal canal is left undecompressed, of course, it will lead to sensory deficits, mainly paresthesias, motor deficits, gait disturbance, bladder and bowel dysfunction, and in the end, the patient will not be able to live independently. So, early detection and progression of a patient with such pathology is very important. And we can use neurophysiological tests to see, even before clinical symptoms arise, to see if a patient is heading towards a direction or not. And also, they are safe to use intra-op and can be very useful during surgical decompression to act as a real-time monitor of what is going on at the level of the tracts. Now, about neurophysiological testing, we basically mainly use SEP, sensory evoked potentials, and motor evoked potentials, with the mention that motor evoked potentials will have a higher sensitivity for the monitoring of the patient's clinical course. Okay, so our question was, can we predict the short-term or maybe the long-term deterioration in patients with intra-op SEP and MEP deterioration? And if so, is there anything useful that we can do about it? The design is the study is a retrospective study. Patients were included if they had clinical myelopathy due to spinal canal stenosis caused by disc hernias, OPLL, and ligamentum flavum hypertrophy. And of course, only patients that had undergone a decompression infusion procedure were included. And of course, intra-op SEP for the medianus and tibialis had to be monitored along with MEP of the tenor muscle and the anterior tibialis. So the idea was to observe, measure, and quantify the intra-op deterioration in the action potentials, to follow the patient and observe its their clinical evolution for a minimum of 1 year, and to look for a correlation between two. And of course, that wouldn't be enough if we weren't thinking of doing something about it. So far, and I must say, and I must be honest, the work has barely just started, so work is still in progress. We only have 23 patients, but we're counting. Out of these 23 patients, in 9 patients, we've seen an MEP deterioration followed by a worse clinical prognosis. But I repeat, this is still raw data. And of course, we have a lot of limitations, and I can just mention a few of them, but that's not the idea. So regarding the results, well, we still haven't got results because we're still working on them. And with that, I'd like to thank you.
Well, thank you very much for this very interesting presentation, and also you're very welcome that you can use my apartment for this week. It's all part of international collaboration and of research. Any way we can help other researchers or our colleagues and our friends, like our colleague said earlier, if we can help our friends bring everything forward, that's all for the best then. Thank you very much, Dr. Padurean.
Thank you.